Audio recording for this meeting has begun.
The intent is to get your input on the QIO program. Next slide, please. In order to do that, we have an agenda that we've laid out for you. So we'll talk a little bit about some of the logistics involved and some of the polling questions we have and how to get your input, both from the people that are here in the room, but also folks that are on the phone and then online as well. But we do want to give an overview of the 11th scope of work, and some ideas are tentatively out there for some of the aims, goals, current and future work for the 12th scope of work. We also want to talk a little bit about partnerships, collaborations, and we also will have a patient who will be joining us a bit later. But again, I think the most important part of the meeting is to get your input. So occasionally as we go through the agenda, we'll stop. We may ask for a polling question to get your thoughts and ideas. Again, our technical people will assist you in how to do that. And then we will wrap it up at about 3:45 this afternoon. Okay. What I would like to do is to turn over to our technical experts to describe some of the requirements if you're online and using the app.
Thank you. Ladies and gentlemen, the easiest way to connect to the audio is to allow Adobe Connect to dial out to your telephone by entering the phone number and then clicking Join. You may also manually join the audio by dialing 1-800-832-0736 and then entering *327343 # To view the dial-in information at any time while you are on the live webinar, please click on the information icon on the top right-hand corner of the screen and click View Info. Also, to view the presentation in full screen, click on the 4 arrows above the slides, and you can ask a presenter a question or share a comment by using the chat pod displayed on the right-hand side of the presentation screen. To speak over the phone in response to our group discussion questions, please get into the queue by pressing *#. And if you are experiencing technical difficulties, please email tcpi_ndmic@luwin.com for assistance. If you are on the phone line but you are unable to log into the event via your computer, you may also access the slides by clicking on the URL here. If you are attending the webinar in person and would like the ability to view the presentation on your phone and participate in live polling during the event, we ask that you please download the Adobe Connect app on your phone at no additional cost. And here below you can find the links to download both the Adobe Connect app. And just as a reminder, to mute your phone once we do go live on the presentation.
Okay. Just some ground rules. You've probably seen ground rules similar to these in other meetings that you've participated in. I do want to highlight a couple of things. However you submit your input, be it here face-to-face, over the phone, or over the chat box, please identify yourself and your organization. We really would encourage those of you that are in the room to use the app because it's going to be very helpful in tallying up the responses and looking at trends. And if you're not able to use the app or don't have that ability, we do have the handout that was distributed to you when you came in today, which is essentially all the questions, and then you can handwrite your responses on that. So again, if you're not using the app, and you're here in the room, just complete that form, and then we'll collect those at the end of the session today. We're going to go ahead and try it out. So go ahead to the next slide, please. We'd like to find out who's in the room. So again, folks that are here, here on the call and the chat box as well. We'd like to get a sense for all the participants. So we'd like to go ahead and get you started on that. So let's go ahead and open the poll, okay? And then what you will eventually see is sort of a distribution of the participants.
So Bernie, this is Dennis Wagner with CMS, and I'm looking at the numbers as we're tallying here, and I'm seeing that the number of patients or patient and family advocates is a relatively small percentage, at least so far. And I thought it was just worth acknowledging to the larger audience on the phone and here in the room that we did have a special listening session just last week. I can't remember if it was Tuesday or Wednesday that was focused on patients and families. And had very strong participation in that special listening session. We thought it was important to do that because there's sort of more detail that might be necessary for patient and family members who are a little less familiar with the bureaucracy and the contracts and those kinds of things. Yeah. So I did just want to acknowledge that for people who are here in the room.
And later on and you'll be seeing a slide or two, we have summarized with that session. So we'll get to that a bit later. Thank you, Dennis. Also very nice to see the large number of providers we have joining us today. And later in the session, Dr. McGann is going to lead a discussion and getting input from, particularly from the provider group. Okay, so I think let's just wait another second or two and okay, let's go ahead and close the poll at this point. Okay. What I'd like to do now is have the folks that are speaking today introduce themselves, and I'd like to start with Dennis.
Hi, I'm Jean Moody Williams. I am the Deputy Center Director for the Center for Clinical Standards and Quality for CMS, and we'll be giving you a little bit more information about that in just a moment.
Hi, I'm Paul McGann. I'm an internist and geriatrician, and I'm the Chief Medical Officer for Quality Improvement.
Hi, good afternoon. I'm Kara James. I'm the Director of the CMS Office of Minority Health.
Hi, everyone. I'm Janine Lugo, Deputy Director for the Quality Improvement and Innovation Group here at CMS. Hi, everyone. I'm Tracy Archibald. I'm the Division Director that oversees the QIO program.
Okay. Did we cover everybody this weekend? Okay.
Great. Thank you. And thank you for coming and being with us this afternoon and spending your time as we really are very excited about having you here and look forward to what you're going to be telling us, because we're going to talk for a little bit, but we're going to listen for a lot. As mentioned, I'm the Deputy Director of the Center for Clinical Standards and Quality, and within our center, we have many of the drivers of change and levers of improvement that we work with, including many of our value-based purchasing programs, our quality measurement programs, public reporting, coverage and analysis. We work with conditions of participation, just many areas. And of course, within that comes our quality improvement work with our quality improvement entities. And we had a delegation from Indonesia here on yesterday, and I had the opportunity to spend the afternoon with them, and I was trying to explain what we do within our center. And they said, so let me get this straight. On the one hand, you are doing corrective actions and negative payment adjustments, and on the other hand, you're helping them and being supportive of them. I said, yes, it is a little difficult sometimes to understand our role. But that is, in fact, we understand that we can be supportive and be change agents in more than one way. And it's very important that we bring all of those drivers of change together. And that's what we're here to talk about today, a very important aspect of this, the Quality Improvement Organization. Now, I'm first going to tell you, I see some familiar faces and some not so familiar faces. So I'm going to take a moment to explain what a Quality Improvement Organization is. And I'm going to start with what our, the legal definition, because Quality Improvement Organizations are around because of statute, because it was recognized many years ago that in order to really have a complete payment system, yes, we need to pay claims, and we need to make sure that we have those processes in place, but that we really need to have a way across the country to have an infrastructure that ensures good quality care. And so by law, the mission of the Quality Improvement Program is to improve the effectiveness, efficiency, economy, and quality of services delivered to Medicare beneficiaries. And we're required to accomplish this mission working to ensure that Medicare pays for services and goods that are reasonable and necessary and are provided in the most appropriate setting, that we help provide protection for beneficiaries by addressing complaints, provider-based notices of appeals, emergency medical treatment and labor act violations, also known as EMTALA, and other responsibilities that really look at efficiency and effectiveness and all those kinds of things related to the QIOs. So that's what the law says a QIO is. Let me give you my definition of a QIO, which is consistent with the law, of course, never outside the law. But really, if I had to put it in my own words, I'd say QIOs are change agents. They use system and method and tools, quality improvement tools, lean tools, all kinds of tools to make change. They are conveners of partners. And you see a number of the partners in this slide that are brought together routinely to talk about issues that are facing our healthcare system. How can we make sure that we are promoting improvement? They foster collaboration. It is not unusual that we bring a group together. The QIOs are facilitating that activity of people that are working with the same patient, the same family, but have never talked to one another and never stopped to understand what that person's contribution is to the healthcare system. They look at the evidence and they explore best practice, and then they facilitate learning. It's a dynamic learning community full of new ideas and innovations and thought processes that can spur change in ways that we may have never thought about before. But not only that, they then spread what we've learned and what we're doing, and looking at new models of care and how they fit into the current structure. They make sense of data. Really knowledgeable about the data sources that are available, how to use that data, how to apply it practically in a practice setting, or helping to chart the course of beneficiary care. And they help to make sense of CMS programs. Sometimes we need help with that. But it's not only just CMS programs as far as sense making. We can see what we're doing here, but QIOs are in the community. So while we may know about the Medicare program and the Medicaid program, and maybe we might even know what Blue Cross Blue Shield is doing and Aetna's doing, but being in the community, local, they know that the county health department just launched this initiative. Let's see how that works together with what's going on with this nonprofit that just got a grant to do something. And it's weaving all of those various things together that becomes essential when you think about what clinicians and patients are facing as they try to navigate through the system. So sense-making is essential. They also help to transform the healthcare system. And that may seem cliche, but when you think about all the programs that are coming down the pipe, it is not unusual that when we begin to sit around and think about, well, how are we going to implement this? How are we going to get this done? Probably a couple of sentences within that conversation, the QIO's name is going to come up. And so just as we're in the midst of implementing the Quality Payment Program, we talked about the Impact Act and all kinds of things, the quality improvement organizations are essential to that. And they help to get results, which I'll highlight in just a moment. But so that's a laundry list of things that happen within quality improvement organizations. But why? Why do they do those things? And that's really the key as to why we are here today. And it's really at the center you see the beneficiary and the family members. That's the reason that we are here. It's the reason that we want to talk today. How do we improve care for beneficiaries, for their families? How do we support clinicians in making sure that they can provide the best care possible despite the system barriers that may be present? How do we work within that to continue to make progress? And we really are interested in learning more each day. It's an evolutionary process. We know a lot more now than we knew 5 years ago, but I'm pretty sure we're going to know a lot more in 5 years than we do right now. And it's through that constant evolution. So we come together today to really continue to plan for the future. And it is going to be in 2019 when we intend to launch the next round of our QIO work, and this will be known as the 12th scope of work. We're currently in the 11th scope of work. And so we're looking for ideas of where do we go from here. And we have to start thinking about that now in order to reach and have things in place so that when we get to 2019, we'll be ready to go. Today's special session really is that opportunity to hear from you, to gather information so that we can refine the process along the way. It sounds like a long ways off, but those of you who have been involved in this program in the past know it'll be here before you know it. Now, this is not new. This is not the first time that we held listening sessions or we send out requests for information, but I think there's a new energy around it because we are really looking at how we design programs that engage the users, the human-centered design. I talked with some of you about that. Really looking to see not just what CMS needs to gain out of this, but what is it that makes a difference in the front line. So I'm extremely excited to see that we had at least, I think, 25% of the folks in here are providers of care. So that we want to be able to hear from you. And then those contractors that are going to make this happen. As we are now implementing our programs, we go and we sit in offices or we watch people put information into computers. And the team here, Dennis and Paul, will know they've had some listening sessions. And I've kind of challenged them to say, well, that's really nice, but what did the clinicians say about this? And so they put up with me. But they want input. So, but really in the field input. So that's why I think we all have a new energy and a new excitement. As they said, they just had a beneficiary session that was extremely invigorating. So the last thing I said when I described what a QIO is, I said that they get results. And that is important because we are using resources, valuable, limited resources, to fund this work, and it is extremely important that we be able to say, without a doubt, here's what we're getting for this. Here's the value in continuing this work. There wouldn't be a 12th scope of work or 11th scope of work or a 10th scope of work if there wasn't some way to show results. And so we continue to look for that. So here's just a few. I'm not going to read them all to you, but look, 24,000 readmissions prevented. Think about that number. And this is just the 11th scope of work, high-level summary. As you know, we're still really in the midst of that, just getting early data from the 11th scope of work. And already we can see the value that we're getting here. The potential adverse drug events that have been avoided because of this work. We see instances where the influenza vaccinations and pneumonia vaccinations are increasing. I just saw some run charts about that because of the work that's in the 11th scope of work. We have, and a lot of that work is being done by our Quality Innovation Network. As you may know, we re-engineered the way we approach our work in the 12th scope of work, and so we now have Quality Improvement Network, which work with on aims and target and bold goals for improving care, and focus really on working with many of the clinicians and providers in the communities that they serve. But we also want to have an entity that's really focused on the patients and families, and that's the Beneficiary-Centered Care QIOs. More than 29,000 reviews that they've done of quality of care concerns. So beneficiaries know if I have an issue, here's where I can take that. And then out of that, finding opportunities across the system upon which we can make improvements. Discharge appeals, you know, how many of us have had instances where even our own family members are saying, oh, you know, Aunt Sally has to be discharged from the hospital. I don't think she's ready to go. Well, we have a system that's in place that can look at that to make an objective determination. So that's why we're here. That's what QIOs do. That's the results that they get. That's the value that we're looking for. And the question to you then is, how do we do more of this? How do we look to where the hockey puck is going? 2019, but just think if it stays a 5-year contract, and we think it is, for the 5 years following that. With all the transition that's going on right now, we need to be thinking about that right now. So I am, again, thank you for coming, and I'm going to turn it to Tracy.
Thanks, Jane. I'm going to turn to the next slide. We wanted to give you a high-level overview of what we're currently doing in the 11th scope of work, which is began in August of 2014 and goes through July of 2019. The Quinn QIOs, as Jean mentioned, are focused on generating outcomes through improvement activities that lead to those results. We have a strong focus on convening communities through learning and action networks to be able to highlight who's doing well in any given area and to try to replicate that on a larger scale. We also have focused on direct technical assistance from experts in the areas of improvement that we're working towards, as well as integrated communications and case review. And our focuses in the current 11th scope of work are, we have a strong focus on reducing health disparities in the areas of improving cardiac health, diabetes and cardiac care. We also have a strong focus on reaching to at the community level to reduce readmissions, improve coordination of care, reduce utilization of inpatient services in general, and to reduce adverse drug events by focusing on communities coming together to improve those outcomes. We also are working in the nursing home setting, targeting a huge number of the nursing homes across the country, 11,000 out of the 15,000, to reduce harm and then improve quality. We're also focused on providing assistance to those clinicians who are participating in the new quality payment program and other quality reporting programs, as well as taking the information from the beneficiary and family-centered care QIOs and using that to initiate improvement initiatives. We also have a number of special innovation projects, as well as subnational work in the area of adult immunizations and behavioral health. Next slide. So this is the focus for the 11th scope of work, BFCC, QIOs, all driven by analytics to create improvement. We have the beneficiary protection side that Jean mentioned earlier that listens to concerns from patients. We have the beneficiary oversight, which does claims review and validation, as well as discrimination reviews and provider sanctions. And then the beneficiary engagement, make sure that we're engaging both the patients and their families and hearing their feedback in real time, as well as beneficiary focus groups. So with that, I'm going to turn it over to Hugo.
Thank you, Tracy. So next slide. So this slide talks about how we plan to do the work of this 12 scope of work. And so this is the part of the presentation when we start to tell you what our plans are. You will very soon have an opportunity to share feedback on what your thoughts are on what we're thinking. So I'll just say that I love this graphic for goals. We want smart goals. We want to set smart goals. And so even though I am the junior of the three executives on the QIIG team, it takes a lot for me to keep up with Paul and Dennis. They are fast-moving, aggressive leaders, as many of you already know. And so I keep in my office Post-its on my whiteboard for like ways to be, right? So I have a Post-it up there that says, soon is not a time. If you're going to set a time for a goal, it needs to have a date. I also have a Post-it that says, some is not a number. Like, you need to know exactly how much you're going to provide on that date. That's a requirement for us, and it's also a requirement for most of the goals that we put in our contract. And then the last Post-it I'll share with you, I have lots of them, is hope is not a plan. So we have to lay out exactly how we plan to do what it is we're going to do, have a date tied to it, and have an exact number for what it is we're going to achieve on that date. And so part of our goal setting is an aim towards achieving national impact for this program. We want to cover the landscape and make sure that we touch as many beneficiaries, providers, caregivers as we possibly can as we do this work. One of our partners in doing that work is the Strategic Innovation Engine, and so we're working with them. We plan to continue to work with them to test and think about and research innovative ideas and use that as a way to kind of funnel into future work. We also want to take all of the innovations that have been developed and scale them for national impact. So Tracy mentioned some of the subnational tasks. We want to test those, look at the outcomes, look at the results, and if they're promising, go big, go larger, go national with whatever it is that's promising on a subnational or a smaller scale. And then we also want to take all of the data and learning from the BFCC, Beneficiary and Family-Centered Care QIOs, take that data and feed it into our quality improvement work so that we're getting the impact that we want, but we're doing it in a smart way. We're using the progress with innovations and with data analysis to funnel into how we're going to do future work, and that's part of our goal setting and how we plan to approach this work. Next slide. So these are our approaches. So one of our top approaches is to maximize competition. We are stewards of taxpayer dollars, and we need to be efficient and wise in how we procure those funds. So competition is a way for us to make sure that we do that in a smart way and that we're wise in how we spend the trust fund dollars. We also want to be flexible on how we do this work. So once we set our outcome and goal, we want to team and partner with patients,
the quality improvement organizations, and providers to determine exactly how that should be done. And we want to be tight on what the outcome should be. We don't want to spend a lot of time dictating to the QIOs or telling you how to achieve the outcome. You're the expert, and you know best. So part of this session is gathering your feedback. We want that to be a continuous cycle where you tell us the best way to achieve the national impact that we're aiming to have. We want to continue to have close partnerships with patients, with other federal agencies, and then also with our private partners. Piling on to what Jean said, we are elated to see that we have so many private partners here with us today because we really want impact from the masses. We know that 5 years is a long time, so we want to make sure that as we go into a phase where we're developing what we're going to do in the next scope of work, we get input from as many people, from as many parts of the healthcare community as we possibly can. So I know that these next two will be favorites among some of you in the audience. We want fewer but more important measures. So we're not aiming for bean counting here. We want to measure the things that matter, measure the things that get impact, and have a few smart measures and not spend a lot of time counting things that really don't add up to increased outcomes. Less reporting and fewer contract deliverables. We need to have deliverables that are smart, that are going to give us data that we're going to use, and data that's useful. We like to use our data in a transparent way, and so making sure that we hone in on the data that's most important and most useful is the way that we like to do our reporting as we go into this next phase. And then lastly, we want to work in key systems, clinical practices, hospitals, communities. This is where healthcare is happening, and we want to partner and work in those settings and set goals and set tasks that are active and achieve the maximum outcomes from the settings where healthcare is being provided. So we're going to go to our second polling question.
Okay.
So this polling question, I'll set it up for you, Bernie, and then I'll get out your way. So this polling question is all about the approaches that I just discussed. So we'd like for you to pick the most important 3 of these approaches and provide us with your feedback. Thank you. A meeting URL for that?
Okay. Okay. I'm sorry. Let's see if we can get your question.
When you do the app, it brings you to enter a meeting URL
Okay.
so that it's for this meeting.
Okay. Can you answer that, Nicole?
I apologize.
Okay. Yeah, I think everybody, for those of you that are online or on the phone, we need to answer a question to help out the people in the room with the app.
Yeah, so once you get to that screen, it's just https:// and then it's tcpi.adobeconnect.com /CMS special session.
Can you read it again?
Can you say it again?
Okay,
Sure.
let's go ahead and just, if you wouldn't mind saying the URL one more time.
Sure.
Okay.
https:// tcpi.adobeconnect.com /CMS special session.
And again, if you're not using the app or having still problems with it, please fill out the sheets that were distributed. Again, I'm addressing that to the people in the room. Okay.
And once you log into the app, just make sure to turn your volume off because otherwise it will broadcast through the phone.
Again, if you're struggling with the app, you do have the sheets to submit your responses, and as I say, we'll collect them. Okay, let's take another minute to do that. By the way, there is an opportunity for open-ended submission of the other hows, and we'll do that in just a minute. But we do, of these 7, again, the top 3. I think Janine was very accurate in saying things that would resonate. It certainly would be focusing on the critical measures and really looking at fewer deliverables and looking at outcomes. Let's take another minute or two before we close the poll, because I want to be sure that everyone has a chance to submit. And again, if any of the speakers notices anything, please.
Yeah, Bernie, this is Paul. I just wanted to point out, like all learning communities, people are getting very adept at this on Adobe Connect with this technology. And if you look at the chat box, for those of you who are in the room here on the right-hand side, and for those of you online, you'll start seeing members of the audience starting to help each other out, typing in the URL that we were having difficulty with, putting in hyperlinks and explaining what's happening. I've also been reading it, Bernie, and I saw a few people seem to be having trouble with the audio on the phone connection. So this is an opportunity for a dialogue with people out there that are listening. I've got a handheld mic here, and if you wouldn't mind just giving us a little bit of feedback, if the audio has improved for you out there, we can try to work on improving that as we go along as well. We want to model as much as possible a learning community as we go along.
Real-time learning community.
Annette says she can hear you, Paul.
Sounds fine.
Excellent. Thank you very much.
Yeah, and I think one of the benefits of a session like this is you'll be seeing comments on the chat box, and you can respond to those as well. Again, learning from others and then sort of building on other people's comments as well. Okay. Because we're having a little bit of problem in the room, I'm going to allow another half minute or so to submit, and then we'll close the poll. So if you keep the poll open for just a little while longer, I would appreciate it.
And Barry, it's Paul again. Sorry to keep talking, but the silence is deafening. But just look at those poll results here in the room and those you can see in the chat box. And I think you could tell by the way Janine Iwugo presented that option. I don't know what number it is, but I'm reading across fewer, more important measures with a focus on outcomes and results. And I was listening to Janine as she read that, and she was really emphasizing it. And I think she even said something like, this will be real attractive to those of you in the room that worked with us.
Yeah.
And she was exactly right. We're almost at 80% of respondents clicking on that one, Bernie.
Yeah.
And that's truly amazing for a triple poll like this, where you can choose 3 things to get, now we're over 80%. So that's pretty impressive, and I thought we should.
I don't think the audience needed to be led on at all by Janine. So,
well, and I think, too, later on, Bernie, we're going to go to some open-ended questions on this as well.
Right
so
now.
People will have an opportunity for things that you don't see on the list that are important to you about the how to give us comments on that as well.
Exactly. As a matter of fact, I think this is a good time to do that. So let's go ahead and close the poll. And then let's move on to the next slide. Throughout the session, we'll have these polling questions, and then we'll have some open-ended questions. Again, we had sort of a forced distribution. We said pick 3 of the 7. Now we'd like to open it up. And so we have 3 mechanisms to get your input. One, of course, would be online, the app that you have. And then we also have the ability for you to speak up if you'd like, actually direct verbal, like back in the old days where people used to speak up in another meeting. And also the people online can do that as well. So let's go ahead and maybe think just a bit and go ahead and however you would like to submit through any one of those different means. And again, if you do have problems with the app now, go ahead and use those sheets if you're in the room. And if you would like to speak up, we do have mics throughout. So I'd like to get Nick and Nancy up, if you wouldn't mind. Nick, if you wouldn't mind going to that mic over there, and maybe Nancy, pick up that mic right there. And then Nick, if you can get that mic over there, then there's a mic right here. So if somebody would like, go ahead, continue to enter your feedback and your ideas while we have a verbal input as well. Okay, so if you are providing, it looks like we do have somebody up. State your name and your organization, please.
My name is Jerry Rogan. I'm a family doctor from California. Came out here for this meeting.
Welcome.
I'm a former contractor medical director for Medicare. And my request is that the QIO statement of work include a disaster analysis of medical disasters that are publicly reported, similar to what is done by the National Transportation Safety Board for airplane crashes, for the organization that analyzed NASA when there was a Challenger crash, and for FEMA with Katrina, and for the intelligence community with 9/11. So there's 2 incident cases of disaster analysis that have taken place that I'm familiar with. The first one I'm familiar with, I wrote myself with 2 doctors from Reading Medical Center, where over 700 patients were damaged. $500 million payout by Reading Medical Center that was kicked out of the Medicare program. 2 doctors lost their licenses. And no government agency, including my contractor medical provider, including my carrier, NHIC, recognized that there was a problem. And a QITAM lawsuit was filed, which identified the problem. And we wrote a disaster analysis. We asked the QIO to write a disaster analysis to find out how is it possible that 700 patients could be damaged in an institution over 6 years and nobody analyzed how it could happen. So we wrote, the QIO refused to write a disaster analysis because it is not part of their scope of work. The second case was in Towson, Maryland, right down the street, where Dr. Mark Madai treated over 500 patients with unnecessary coronary stents. He lost his license, and the disaster analysis was done by the Senate Finance Committee Subcommittee on Health, which is published online. And that is the second disaster analysis I'm aware of. Other than those 2 disaster analyses, there is none. So when St. Helena Hospital in California was tagged with a $4 million payout for a QITAM lawsuit for damaging several patients, like 3 cardiologists, I called the QIO and asked them to do a disaster analysis. They refused. I contacted every other federal agency that there is, including the FBI, the OIG, State Licensing and Certification, the California Medical Association, the Institute for Medical Quality, and the Medical Board of California. And all of them refused to do a disaster analysis. In my opinion, the public must know how it's possible that in an institution where program safeguards are in place, that despite those program safeguards, patients can be damaged over several years by several doctors without any accountability at that time until they get popped by a QITAM lawsuit. Basically, a QITAM lawsuit that's successful means that the government failed to find the problem. So that is the problem, is that the government failed to find it. My contractor failed to find the problem at Reading Medical Center. So that's a failure. It's a failure of data analysis because we just don't find it. So we must now move forward to do what the National Transportation Safety Board does. And we need to have a national patient safety board that will look at these kinds of problems, and even if it's de-identified, report the findings. So the incident cases can be found from the Department of Justice because they settle these cases or they litigate the cases. So the cases can be discovered, and then the details can be analyzed by the QIO, de-identified if necessary in order to comply with a court settlement where the information is tried to be kept confidential so that patients can't find out. And then we can move forward to know where our mistakes have been, where our institutions and program integrities has failed us, where the conditions of participation have failed, and then we can fix the problem and have better health care moving forward.
Thank you very much.
Thank you so much.
Thank you. Okay. do we have somebody else in the audience that might speak? Okay. What are we noticing online? Anything that we're noticing in the chat? Okay. Okay. Okay, great. Okay. A couple of comments that we're getting. What I have is I have Denise and Susan over here that are helping digest or synthesize comments that are being made in the chat box. A couple of things that are mentioned was really working with patient groups, really allowing flexibility during the scope of work, and also focusing on rural health specific concerns. And also, we also noticed a trend dealing with cross-cutting work and more work collaboratively across healthcare settings. And really aligning, the other comment that I thought was interesting is aligning measures across settings. So again, these are some of the trends that we're beginning to pick up. I wanted to ask, Patricia, can you hear me okay?
Yes, your audio is coming
Okay,
in.
is there anybody in the queue waiting to speak?
Currently, we have no participants on the phone line.
Any other comments from the audience? Yes, one more. One more, then we're going to move on.
Hi, I'm Natalie Graves with the American Hospital Association. Here on behalf of the HRT Hospital Improvement Innovation Network. I would just reiterate many of the comments that are coming up in the chat. I think something we've seen that will be important to continue is continuing to be intentional about supporting the work across multiple care settings and across the community. Some of the topics that we're focusing on that continue to be the most challenging, including readmission, sepsis, adverse drug events, antibiotic stewardship, all of those are impacted in care settings across the continuum. So though we're working with inpatient, in the inpatient setting, we can't make an impact without support across the continuum. So continuing to support the work in that way.
I think we have one more comment, then we're going to close on it. But I want to mention that one of the ground rules is to keep your own parking lot. So please, if we don't get to you, be sure you enter it on the chat box. We will record everything and consider everything as well. One final comment.
I'm Tina Georgie with Great Plains Quinn, and I would like to emphasize the ongoing flexibility of submission of a maybe state or regional project that may be identified by the data analysis that's being done in our Quinn regions as we propose on work. I can speak to a special innovation project that Great Plains Quinn has been doing over the last year around colorectal cancer. And I think if the ability to allow the Quinns to propose on a project that could span the full 5 years really would address issues around health equity and population health because of knowing our own populations and being able to identify areas that our providers would find most important to work on.
Thank you very much. Well, again, appreciate all your input. Again, even though we didn't get to you verbally or I didn't identify a trend, please continue to enter items in the chat box. And again, those people in the room, there's spaces for each response. So I think I would like to turn it over to Dr. James. Okay.
Thank you. And again, good afternoon to each of you. I am the director of the CMS Office of Minority Health, and I was asked today to talk a little bit about collaboration. And you've heard from each of our speakers, from the comments on the chat box, about the importance of collaboration and partnership. And I'm so pleased that we just had the comment about allowing flexibility to focus on health equity. I support that. Second that. But one of the reasons I think we might have been asked to talk a little bit about collaboration is because if you look on the next slide and some of the disparities that we see in our healthcare system and healthcare quality, we can't achieve our goals of reducing disparities without collaboration and partnership. And throughout all of our work, we are working across the spectrum of healthcare systems and others to focus on this. And as you all know in the work that you're doing, when you look at the next slide, to reduce those disparities in quality, we can't just focus on medical care. And so on that, okay, so there, as you know, and you guys have seen this, you pick your article, medical care results really in just about 10% to 20% of our health outcomes in terms of its contributions. So we really need to think about those behaviors, social circumstances, and other factors. And that means that we need to work collaboratively to do that. So on the next slide, it shows some of the work that we've been doing in the collaborations across CMS. We can't get to our goals without that collaboration here in terms of achieving health equity, and it shows some of the ways in which we've been able to do that. We're working to implement our CMS quality plan for improving, equity plan for improving quality in Medicare, as well as within, you've heard already about the QIO's 11th scope of work, the focus on health equity in a number of places, which we're really excited about. Transforming clinical practice initiative, focusing on those small and rural providers and others who are disproportionately serving some of these underserved communities to get them ready for delivery system transformation and health reform. And as we're really excited about the latest one in terms of the accountable health communities, where we're focusing on some of those social risk factors and social determinants of health working across spectrums. And so that's also, we just launched with, someone just mentioned rural, our Connected Care campaign that's focusing on chronic care management in collaboration with the Federal Office on Rural Health Policy, targeting rural communities as well as providers and those who are racial and ethnic minorities to help them become aware of chronic care management services that are available to them. So on the next slide, we really sort of want to encourage that approach across why collaboration makes a difference. And as our colleague Jean moved, but as they know, collaboration makes a difference. And so I'm sure all of you are aware because they were so gracious in sharing in this, but when they were awarded the SAMI Award for the efforts that they've done on Partnership for Patients, these were the statistics that were out at that time. And we know that since then, they've already seen increased improvement. So instead of 87,000 lives, we're at 125,000 lives. And instead of the 2.1 million fewer medical errors, that number has increased to 3 million, and savings have grown to nearly 30 billion. And so collaboration works. Those goals wouldn't have been achieved without the work that I'm sure many of you here in the room and on the phone and in the internet participated in, but it is what collaboration can achieve. And so as we think about moving forward, that next slide, it shows, what you've already just said, collaboration across the health system that we're talking about here in our work and working with our colleagues, but also how do we get all the way down to the level of the individuals that we're trying to help and supporting that. We all have expertise in given areas, but it's through our collaborations across these levels that we really can achieve more of those goals that we're looking for. And so as we're heading into the next phase and thinking about our work on the next slide, I'd like to just kind of leave you with a bit of a thought. There are a number of partnerships that are challenging you to build some bridges to those you may not normally think about partnering with, to expand the pool of collaborations that you have and to see where there may be gaps that we have in terms of what we can do. And it's building those bridges to bring in more people into our tent that we will further drive the outcomes that we have. And just as a final thought would leave you on this next slide, we would welcome the opportunity to collaborate with each of you in your work to help you in achieving that path to health equity and improving quality of care outcomes. And you can learn more about some of the work we're doing and the resources we have on our website. And with that, I will turn it over to our colleagues, Dennis and Paul.
Yeah, thanks so much, Carol. I'm Paul McGann.
And I'm Dennis Wagner.
And on the slide now, if you switch to the next slide, you'll see a daunting task. And we've set ourselves a bold goal of getting through all 11 categories of work in the current QIO 11 statement of work in the next 3 minutes. So those of you, I'm not timing myself because I'm skeptical about I'll make it, but I will start us off with B2, which is diabetes care. And the reason I want to start there is just because of what Dr. Kara James just said. In our QIO diabetes care, which I was privileged actually to be involved at the very beginning of that many years ago, it's diabetes self-management education, mostly for low-income minorities with diabetes. And it's one of the tasks in the QIO 11 statement of work that we already have hard data that it has a positive return on investment. So this is a really good idea. It speaks not just to medical, but to social factors, and it's effective because it has a return on investment. And it's a really good illustration of everything that Kara was just talking about. So that's an example of work that makes a difference in the community. Dennis?
Yeah, and I'll pick up and just talk very quickly about the work that's currently going on in the 11th scope in the area of care coordination and medication safety. We have a substantial program currently underway. You heard a little bit about this from Tracy Archibald right at the beginning when she sort of briefly covered the 11th scope. But QIOs currently are working with 294 communities across the country in community-based coalitions to try to reduce unnecessary admissions and readmissions. Patients who are discharged from the hospital, kind of the last thing that any patient wants is to go back to the hospital. People want to be discharged from the hospital and stay healthy and out of the hospital. And when that happens, the patients are better off, and it also reduces costs. Similarly, these 294 communities are also teaming with Quinn QIOs currently to address medication safety. We focus in the 11th scope of work on the highest risk medication safety issues, which include opioids, which is a significant challenge that I think all of us are very familiar with. This is something that we have high on our priority list, both for the current 11th scope of work, and you'll hear more about it shortly as we advance to the 12th scope of work. I will just mention that our, again, initial results, Dr. McGann talked a little bit about the return on investment, but the initial results on the care coordination front, you saw Jean Moody Williams share right at the beginning. We estimate an estimated 24,383 fewer readmissions as a result of this work, which does translate to over $200 million in savings to the American taxpayer and the American healthcare system as a result of that care coordination and medication safety work.
I'm going to direct your attention next, and don't worry, we're not going to do all 11 of these, but I'm going to direct your attention to C2 on the screen, which is our nursing home care task. We have a really robust program of work in the nation's nursing home. In fact, we've currently enrolled over 11,000 of the nation's 15,000 nursing homes in this quality improvement work. And we have a number of different measures. One of the ones that's had one of the biggest impacts is a project to reduce the unnecessary use of antipsychotic agents, which are associated with diabetes and early mortality, and that project has been quite successful. We also have composite measures that include 13 different types of measures, such as how nursing home residents are improving their mobility, the reduction in infectious diseases such as C. diff, and the reduction in falls and injurious falls, and many other measures as well. So this is a robust piece of the work that we're doing currently in the 11th statement of work. We're asking you here today to think about the 12th statement of work, and I want to highlight another thing Kara said, which is collaboration. I was around when we introduced the robust work in nursing homes in the QIO. This was many statements of work ago. And we had many partners, but two very powerful nursing home association partners, the American Healthcare Association, and at the time it was the American Association of Homes and Services for the Aged, we used to call ASA. The latter organization has since changed their name to Leading Age, and I actually see one of the leaders from Leading Age here, the Senior Vice President for Policy and Chief Medical Officer, Dr. Cheryl Phillips. So we're very glad to have this continued partnership and engagement, and we invite all of you to comment on this very important sector of work.
Now, one of the things that has been a central element of the QIO program for many years is to assist providers in complying with the reporting requirements associated with various Medicare payment programs. That, again, is a significant element of the QIO 11th scope of work, and it has taken on particular significance with the bipartisan passage of the MACRA statute and the resulting quality payment program. So QIOs are accountable, together with the Transforming Clinical Practice Initiative and the new SIRS program, for assisting nearly 400,000 clinicians across the country with the new reporting requirements that are associated with the quality payment program. QIOs also work closely with hospitals and other providers who report to Medicare, but that is a very important part of this work. Our intention is to provide exceptional customer service and to reduce burden in every way possible. A key element of the program.
I'm going to join with my partner here in an effort to hit this 3-minute deadline. I have no idea how close we are, but to do that, I'm going to combine two into one. So B1 is cardiac health, and I'm very pleased to say that the QIO program, it always has been, including in the 11th statement of work, but we forged an even closer partnership with Dr. Janet Wright and the Million Hearts program, which is co-led by CMS and CDC. and Janet Wright is now a formidable part of our program. Cardiac disease, cardiovascular disease, acute heart attack, stroke, and heart failure are the #1 causes of death in the United States still, and this program is really a prevention program that addresses the ABCS of that type of work, to get everybody who needs it on aspirin, to control hypertension, to control high lipids and cholesterol, and to especially get people to stop smoking. That's the way to reduce the burden of cardiovascular disease. The other one in this vein is antibiotic stewardship, C310 on this slide, and we've really expanded that with the help of our partners at CDC. We're trying to work in as many different settings as we can, from hospitals to nursing homes to physician offices, and even trying to get into cutting-edge facilities like dialysis facilities, ambulatory surgical centers. Absolutely key to preventing healthcare-acquired infections, and we have active programs of work that are expanding in those areas.
Yeah, and I'm going to take a page from Dr. McGann's book and just hit 3 of these very, very quickly. Our purpose in sharing this overview of the QIO 11th scope and drilling down a little bit deeper than what you heard already from Jean Moody-Williams and Tracy Archibald is we're going to ask you to identify the 3 areas here that you think are most important for continuation. It may be that we'll continue more than 3 areas or fewer than 3 areas, but again, as part of the work of gathering input, we're going to ask your advice on that in just a few moments.
And then right after that, Dennis, we're going to give you a preview, because we've had a lot of these sessions already with individual groups, of what people are telling us. But right now, we want to focus on what we're doing now.
Exactly. So on the behavioral health front, you heard earlier from Jean Moody-Williams, QIOs are working with 1,400 practices across the nation to increase behavioral health screening for things like depression. On the Transforming Clinical Practice Initiative, quality improvement organizations have a very important role in supporting 29 practice transformation networks in conducting assessments of clinical practices that have voluntarily joined the Transforming Clinical Practice Initiative to prepare themselves to thrive and prosper in the advanced alternative payment programs. And then on the immunization fronts, another area where a tremendous amount of work has gone on over the years, more than 328,000 immunizations have resulted already as a result of the work of QIOs in the 11th scope of work. So that's kind of our lightning tour of the 11th scope. We haven't covered obviously everything, but we wanted to give you a sense of that as we move to our polling question number 3. So our challenge to you is to identify kind of the top 3 things that you would say should be continued from the 11th scope as we consider the work of constructing the 12th scope of work. So we'd welcome your input on these 3 questions.
And just as you're thinking, that doesn't mean necessarily continued as a carbon copy of what we're doing now. We are a learning community. We always want to do things better. So some of you in the audience might have special abilities or knowledge of nursing homes and think, well, I'm glad you're in the nursing homes, but you really need to improve your intervention to reduce antipsychotic agents in some specific way. We're completely open to that. So as you answer the question, it can be both exactly what we're doing now or what we're doing now with improvements and enhancements.
Absolutely. Now, the public input to this process is critically important to us. We also, of course, want in every way possible to align the work of the 11th scope and of the 12th scope as we construct it with the priorities of the new administration. And I will just say that we have heard consistently from Secretary Price that behavioral health, opioids, obesity, these are some priorities that we're hearing from Secretary Price. I want to call those out. We have work underway in all 3 of those in various ways as part of the 11th scope of work. But again, that's another one of the inputs and factors that we consider as part of the development of the new work and the alignment of existing work.
Great. So Bernie, we'll need your guidance as to how long these are complex polling questions, so I'm sure they take longer than normal.
Check in here. I just wanted to do a quick announcement. If you're still having trouble accessing the app, we do have printouts with the login over here, and if you need help, just walk on over and we'll help you get access to the app.
So live help here in the audience for anybody who's having trouble. We have a lot of gurus and wizards available, so go right over to Monique if you'd like her to help you get online. I think we're just about ready to have in the close poll. Clearly looks like about 10 I'll just make an editorial comment here. I'm probably not supposed to do this, but I've been with the QIO program for 15 years now, And I think it's something like 30 or 35 years of work to improve immunizations. And immunizations are great, and they should be improved, and we're working on them now, and we are improving them. But I do see trends here, Bernie, that, you know, immunizations, as important as they are, can be rolled into other projects like practice transformation or even care coordination. And so I think people, as they get more sophisticated in their relationships, are learning how not to have siloed tasks that are exclusively focused on one or two narrow measures. And maybe this is, the polling results here are an expression of evolution of the community as well. I'm going to go ahead and close the poll, and we have some friends that are filling up online, and I'd like to share some of those. So we're going to go ahead and close this poll, and then we're going to move on just a minute. One of the features that we're picking up is and really looking at social services. Another trend that's information in advance about that, information about background, and then a lot of stuff around communication on measures to providers and also increasing communication with patients and beneficiaries, if you will, about opportunities to help face QIO work. So I just wanted to share those with you, families that they are with you.
Okay, can all of you hear me now? Okay, let me repeat this one more time. Trends that we're seeing online in the chat boxes are rural health, social determinants of health, advanced information on macro, increased communication on CMS measures, and also increased communication to beneficiaries on how they can help shape QIO work. Okay, so we'd like to go ahead and talk about some of the future work.
Great.
So let's go to the next slide.
This is the most exciting part of all. So for those of you who are fading off, like this should be like a double dose of espresso for you, right? So we've had several conversations with many of our partners. We're not finished yet, but this is by far the biggest session we've ever had. We're on slide 29. Well, at least mine said, there it is,
yeah,
slide 29.
Yep.
And it has a table in front of you, and we're going to sort of pick and select ideas that we've heard as we're preparing for the 12th statement of work. Remember, we're halfway through the 11th statement of work. We now have 5-year statements of work, no longer 3 years. That just changed this time. And our next statement of work, the 12th statement of work, starts in 2019, and it runs for 5 years. And these are the ideas that we're getting from talking to people like you in sessions like this. And I'm going to start with behavioral health. My wife's a psychiatrist, as it turns out, and this aspect of care reminds me of what Kara said about the social determinants of health. It's often neglected, it's often compartmentalized, and it's often put to the side. And we're just hearing overwhelming support almost wherever we turn, primary care, specialty care, and even getting out to care coordination, that we have to learn as a country how to bring physical health and primary care together with behavioral health in the same place. And it turns out the specialty of psychiatry has studied this and figured it out and published in randomized controlled trials that a collaborative care model works very well to do this. And that's what you see in that first bullet, integration with physical medicine. And that's one of, I would say, the most frequently cited improvements that we don't have currently that we would like to move to in the 12th statement of work. We'd be interested in your opinion on that. This integrates then with substance abuse programs. It's not just depression. It's not just bipolar disorder or schizophrenia. Substance abuse has become epidemic in the country, and that links to the first box on opioid abuse as well. And we're hearing that as a priority from this administration, and it's certainly coming up in every single listening session we've had. So if any people in the audience have opinions on this, we'd very much like to hear not just what you think about these topics, but specific suggestions as to how to do it best. Dennis?
Yeah, very good. And I just on that last point that you made about specific suggestions on how to do this best, I just want to compliment what I'm seeing coming into the chat. I am seeing a lot of people who are commenting on the specific things that we're talking about, but then they're making very specific suggestions about improvements in how we do the work. And I want to thank people who are doing that and encourage you to keep right on doing that. Again, we're sharing this overview of potential new work for the 12th based on a lot of listening that we've already done in sessions like this. We've consulted with many federal partners, the Centers for Disease Control, the Indian Health Service. We've consulted with patients and families. We mentioned the very large listening session that we had last week on that front with clinicians, and we intend to do more of this. But this list that we're sharing with you comes from all of the interactions that we've had so far. So we've been iterating this list as we've gone forward, and we'll continue to iterate it based on what we hear in this session. We're not able to talk about all these things, but I will mention patient safety. You saw earlier, Kara James shared with you the national results that we've been able to achieve across U.S. hospitals. We are currently working with 4,000 of the nation's 5,000 hospitals as a support contract to the QIO 11 scope of work. We're seeing significant improvements and reductions in harm, which result in cost savings and result in life savings. So this is, again, one of these issues that are coming forward for the 12th scope that people are saying that we should consider continuing as we move forward.
Now, you were talking about patient safety. I'm going to move to diagnostic errors. Would that be acceptable to you?
Sounds good.
So, and I want to use this time as well as a cue to give one of our colleagues, a very special guest, who's going to join us in about 5 minutes. And that's Sue Sheridan. I'm going to tell you more about her in a minute. But if Sue Sheridan is on the line, and I'm told she is, this is your 5-minute warning, Sue. I'm going to call you back at slide 33, and we're going to go over some of those together, and then I'm going to turn the microphone over to you. So 5-minute warning for Sue Sheridan. And the reason I'm reminded by that is because Sue and her family have been tragically affected by diagnostic errors. And I'm embarrassed and sad to admit as a physician that as scientists and university academic centers are studying the accuracy and the timeliness of diagnosis in medical centers in the United States, they're learning something very similar to what we learned 15 years ago for the IOM on safety. And that is, we're not good as a profession at diagnosis and diagnostic accuracy and diagnostic timeliness. And sadly, it's not just a matter of getting the diagnosis wrong. Patients are actually harmed. A lot of patients are harmed by diagnostic errors, and Sue Sheridan's family can tell you specifically about that. So one of the topics that's coming up, it's very hard to measure. We've had several sessions with the HRQ and other experts on this, and we don't have a perfect measurement system, but we're thinking it's important enough, and it won't start until 2019, that we're putting it at the top of this second column. So that's a brand new area that we've never gotten into before that we're strongly considering.
And I'm going to, if I could, I'm going to go back to the first column and talk a little bit about administrative burden and burnout. This is something that we are hearing consistently, which is why it's on this list. That requires attention. Part of the attention and so we're talking about clinicians, physicians who are experiencing tremendous change in the American healthcare system. And they're dealing with changes in reporting, changes in pressing health issues like opioids, for example. Lots of changes in the overarching system of care that they're operating within. And we hear a lot about burnout. And this is an area that's been identified as a key potential area of new work for the QIO 12 scope. Dr. McGann and I had the opportunity not long ago to hear former HHS Secretary Mike Leavitt speak about transformation, the journey of shifting from paying for the volume of services to paying for value. And his belief was that really one of the principal rate limiting factors in doing that better and faster is really it's the clinician workforce and the tremendous burdens that are associated with the admittedly more complex work associated with paying for value. If you're paying for value, we have to count and measure things in new ways, and there's burden associated with that. So this is one of the areas where we are looking for the 12 scope of work. Now, the wonderful thing is, and you'll see an unusual word for a government slide here. The word that I want to point out is joy, creating joy in work. And one of the extraordinary things that we see all the time in our current work as part of the 11th scope is that clinical practices, hospitals, individual clinicians that have figured out how to prosper in the current environment experience joy. And that really is the goal. It's not just reducing burden and dealing with burnout. It's helping to bring back the joy that attracts so many clinicians to this work in the first place. And we see this happen. We see this happen in the work that's currently going on in hospital patient safety. We see this happening in work that's currently going on with the Transforming Clinical Practice Initiative. We see this going on with many elements of the 11th scope. And the challenge, I think, is really to kind of do this with system and method. So that's one of the things that we're looking at for the 12th. I have to just kind of quickly, speaking of joy, Janine earlier on called out Dr. McGann and I as a member of this executive team. And I will just say it is a joy to work with an executive like Janine Rugo. Now, you might have heard her say she was the junior partner. That's Janine. One of her many skills is she's highly diplomatic. So, like in common parlance, we'd say Paul and I are old, and Janine is younger. All right, but that's the kind of way that Janine often brings joy to the work that we have here.
And the last of these topics I'm going to just point to you, because it is a shift in the way we're thinking the QIO program, is the second one in the second column, and that is chronic kidney disease, otherwise known as CKD. A lot of people don't realize that one of the benefits of the Medicare program in the United States is that it agreed early on to undertake not just elderly and disabled people's care, but the care of all people with severe end-stage renal disease and dialysis in the United States. And that currently costs about $30 billion a year, regardless of age. People on dialysis are cared for and are eligible to be Medicare beneficiaries. A lot of people also don't know that there's a tiny parallel program to the QIO program known as the ESRD Network Program, also authorized in statute, that is charged with the same thing the QIO program is charged with within the dialysis community and the ESRD community. But that sort of reality, which has been present now for decades, often overshadows a causal analysis of this very important community, which tells us with basic medical facts that you don't just wake up most mornings and need dialysis. There's a years-long process, typically, depending on the cause, that leads to end-stage renal disease. And unfortunately, the ESRD program isn't authorized to get into that. And they've been asking us for years, and it's always been seen as a siloed issue that we can't really get into kidney disease, right? There's another program. But this time, we're thinking differently, and we're meeting with National Kidney Foundation and other advocates and patients themselves, including dialysis patients, who are telling us, if CMS got involved early on in kidney disease and reached out in a patient-centered way, we could prevent a lot of the progression to end-stage renal disease and the need for dialysis. And that's a new way of thinking for CMS, and that's what's represented on that box. So it's an important problem. It's kind of a tricky problem with our various statutory authorities, but we're seriously considering that it's time now for the QIOs to move in that direction. We'd be very interested in your thoughts on this.
Yep, and I'll just mention one additional item. This appears at the very bottom of the slide, value-based purchasing, quality payment programs. This is work that we are currently doing in the 11th scope, but we know that these programs, the trajectory and the history of these programs, both looking backwards and looking forwards, is that we should expect continued evolution. And our belief is that, and the input that we're hearing, is that QIOs need to be positioned to continue to provide support and customer service to clinicians, to hospitals, and to other organizations that will have reporting requirements associated with the Medicare program. So that is another element of the 12th scope that in some ways is continuation, but in some ways we think is new. And so we wanted to include that on the list. And again, this is all now to get your input around the top three tasks for the QIO 12th that would be potentially new tasks that we've tried to very briefly outline for you. We'd like to ask the people in the audience, both here in the room through the app and then people who are participating via the WebEx and the audio lines to please pick your top three.
And again, Dennis, before they do that, I can hear people's wheels going around in their heads now, and I think I see an improvement in the order here. I just want to let you know, in case you can't see the slides ahead, 2 slides from now, Dennis and I are going to be talking about cross-cutting areas. There are some topics that we think are of top priority, but we couldn't pin them in any one of these individual silos. And just to say them, those topics are Kara Jane's topic, health equity, person, patient, and family engagement in their care, and even the design of systems for their care, and rural health. And we're going to address those topics separately. We didn't put them in any of these siloed topics because we actually think all three of those topics belong in all these categories, and that's coming up. So for those of you who are going to say, what about person and family engagement? I want to let you know we're going to talk about that, and then I'm going to talk with Sue Sheridan a little bit as we get to that.
Very good. Okay, the poll's open, so...
Poll's open now. Just a little note for improvement, Bernie, as we go along here. Maybe it's because my eyes are so old being a senior person, but I'm having a really hard time looking at the column on the left and drawing a line to the right bar on the right. So I think in future iterations of polling, that would help someone like me.
Thank you, Paul. Okay. Will do. Okay, clear trends now towards chronic disease management, behavioral health. And yes. Palliative care.
Someone's asking to scroll down, care. Please.
Thank you. Yeah, palliative care, yes, of course. There we go. Yeah. Yes, thank you. Very good. Mm-hmm. Yeah, so those right now are the big three.
And they're selecting 3 topics each, right?
They're selecting 3 from this list, right? And then we'll have another opportunity to provide additional input for things that are not on the list as well. Okay, so I think we're going to go ahead and close the poll now because we need to move on. By the way, some of the trends that Susan and Denise have picked up that we haven't mentioned before is medication reconciliation across facilities and settings, end-of-life care, and prevention. More focus on prevention as well. So again, thanks for all the input that we're getting online and continue to provide that. Again, because of time limitations, we can't get to everyone and not recognize everyone. So thank you. Okay.
Okay. So I think we're moving on to a focus question now, if I've got my order right here. And this is that right, Bernie?
Not quite yet. But,
no?
But you know what?
I see it on the screen.
Okay, there we go. Yes, there it is. Okay.
I thought I had that right.
Okay, we're ready to go now. Okay,
yeah, okay, good. So what other initiatives should be included in the 12 Statement of Work? And this is kind of open-ended, right? So for those of you online or even here with your fancy phones, you can type in the chat. And it's another opportunity, I believe, Bernie, for people in the room to
by all means.
Stand. You don't even have to raise your hand. Just stand up and go to the microphone.
That's right. And again, we, if you would go to the center microphone because the other ones we're having some trouble with. Go ahead.
Jerry Rogan again from California, family doctor, ER doctor, former Medicare administrator in California. I was in charge of off-label drug use for anti-cancer, and I'd recommend that drug safety, drug effectiveness also be included along with safety. And the reason for that is that the Medicare pays for off-label use of anti-cancer drugs. I know because I approved them. And that often the data is based on just a few patients, a couple of studies. According to the Medicare manual, it's allowed to be provided, and Medicare pays for that. But we don't collect enough data to know when it really works and how bad the patient's cancer really is when the patient gets the drug, and whether it really works or not. And so we're spending a lot of money on drugs where the effectiveness of it is really not quite so clear. And not clear enough to get an FDA approval for that particular use of that particular drug. That's why it's off-label. So in that area, I think we need to collect better data. And so I suggested that to the California Medical Association, that we get better data on the outcomes and effectiveness of off-label use of anti-cancer drugs, and the Medical Association agreed with that. And I think that the oncology community is trying to do that with some of their initiatives to get better granularity of data. Other than that, it's not the ICD-10 coding system is not sufficiently granular to tell us exactly what works and what doesn't. So I'd like to suggest that we look for a better way to collect granular data on the effectiveness of off-label use of anti-cancer drugs, particularly second and third line, and that ties into your initiative for end-of-life care. And when should a patient start to hear from an oncologist that life is, nobody gets out of life alive, basically. So
thank you very much.
Okay. I have one more comment in the room, and then Patricia, do we have anyone in queue?
And there are no participants in the queue at this time. As a reminder, please press the *# to join the question queue.
Okay, go ahead, sir.
Hi, I'm David Schulte with Health Quality Strategies. You already have noted under palliative care that you have the idea of helping support beneficiaries, understanding their options and so forth. I wanted to underscore the need to support practitioners who don't receive on a systematic basis training in how to engage in these conversations about advanced care planning, advanced illness, end-of-life care. And they're really out there on their own making it up as they go, which is a terrible position to be in. It's such an important topic. It links very well with your value-based purchasing initiatives. MACRA, the MIPS program, has good measures, NQF-approved measures to help measure the practitioner's performance in this area, to measure whether patients are getting referred to hospice, whether they're getting referred too late. The oncologists, actually, just to follow on the last speaker, have done a tremendous amount of work in developing these measures. And cancer patients are a great population to be trialing this in, frankly, because there's more knowledge about their prognosis. So great patient-centered opportunity and to support the practitioners and link up with transitions of care and value-based purchasing. Hopefully link up. Thank you.
Thank you very much.
Okay, just one final comment and we need to move on. Again, this is coming trends from the chat boxes: telemedicine, telehealth, sepsis, obesity, medication management. Thank you. Okay, please.
Moving on.
Yeah.
So I have special instructions for the slide changer. I hope the slide changer's in the room or at least can hear me. So if you go to the next slide, which is cross-cutting topics, just for a moment. It's easy to remember, right? So Kara James, health equity, person, patient, and family engagement, getting patients themselves and their caregivers more involved in their care, and rural health. So you got those three topics. And then I'd like you to go backwards in the slides to slide 30 or even 29 might be better. Backwards, please.
Good job.
One more.
Yeah, again.
One more. And one more if you can. There. Actually, that's not so clear to me. Is it clear to you?
It's a little fuzzy.
Let's go back to 30. Again, it's probably my eyes, but I can read that better than that. So the reason I wanted to go backwards is because if you look at those topics and then you go through the three we just looked at, health equity, person, patient, and family engagement, and rural health, and you go down those topics, you can imagine health equity projects, measures, and priorities in every single one of the topics on the board. Similarly, patients and families should be engaged at every one of these and possibly even more. We're starting to toy with the idea, and I'm going to speak to this in just 1 minute, of actually bringing patients into the design process of the QIOs, of the ESRD networks, and asking them how would we design safe systems, for example. And then rural health, I think, cuts across everything. Just because you live in rural health doesn't mean that diabetes isn't important. It doesn't mean that antibiotic stewardship isn't important. So literally every single one of these topics should, and we intend to make it in 12 statement of work, overlap with cross-cutting areas. Now, you may have ideas of other cross-cutting areas that are like this. We're open to those suggestions. We don't have a specific question because we want to give this time to Sue Sheridan instead. But please go to the chat box and type in other areas if you're thinking of them. You can go back to slide 32 now, just one more time, the cross-cutting areas. And then what we're going to do for the next 5 minutes or so is actually spend time talking with a patient advocate who's one of the most unique patient advocates in the world. So focusing on the middle cross-cutting area on this slide, person, patient, and family engagement. And that person is a person that I've had the privilege to work with now for almost 10 years. I first met Sue Sheridan when I was the co-director of the Partnership for Patients. And I am so pleased to be able to tell you, after spending 5 or 6 years as a director of patient engagement at PCORI, we were able to convince Sue Sheridan to come as a patient advocate and as an advisor to us to work at CMS. So Sue Sheridan is actually now a CMS employee, is engaged with us in the design of the QIO 12 Statement of Work. So Sue, I want to welcome you. Are you on the line, and can you hear me?
I am on the line. Can you hear me?
Yes, you're very clear, and thank you so much for joining us. I didn't actually want to do slide 33, even though I was assigned it. I did want to put it on the board, and it's on the board now so our audience can see it. And it goes over things that I think are self-evident, like coordination of care, communication, patient safety, of course. My favorite of all the things on here is the fourth bullet down where it says understanding all costs of care. I think one of the defects in the U.S. healthcare system is lack of cost transparency to patients. I've experienced this in my family and my family members. I know, Dennis, you've experienced it as well. And Sue, I just wanted to turn it over to you to talk to our audience a little bit about your perspective and how you're helping us at CMS see the world with different eyes.
Sure. Well, I'll start with, thank you, Dr. McGann, and let me just tell you, it is a privilege. And Dennis, you used the word joy. It is a joy to work with CMS and to be part of transforming our healthcare system to be safer and better. And I just want to underscore the importance of this webinar. There's so much energy, and I always love doing CMS webinars, and there's reading the chat boxes about all the ideas and innovation and the energy going on. It's just, it's infectious. So what I want to, in this presentation, it's going to be quick, but I'm really wearing two hats. Like Paul said, I'm now the advisor of patient family engagement at CMS, but what really brought me to CMS was, were two really significant diagnostic errors that took place in my family, like Paul mentioned. My late husband, Pat, experienced the failure to communicate a malignant synovial cell sarcoma that went untreated for over 6 months, and once we discovered it, it was too late, and Pat lost his life when he was 45 years old from the simple failure of communicating a malignant pathology, something we need to really focus on. 4 years prior to my husband's misdiagnosis or his diagnostic errors, my son, no longer young, but I used to call him my little boy, but he's not. He's 22 now. But he suffered permanent brain damage when he was 5 days old, when he was a newborn, from his newborn jaundice that was not treated or tested appropriately. And so today Cal has cerebral palsy, hearing impaired, speech impaired, has a lot of challenges in life. I have to share. He's smart, he's funny, he's a delight, but shouldn't have to live with the challenges that he has because of the weak links, I call it. My family really saw and experienced the weak links in our healthcare system. And I know I couldn't change what had happened to Cal or my husband, but I definitely wanted to be part of a solution. And over the past 20 years, I've been engaged in patient engagement and family efforts in research, in policymaking, in healthcare delivery systems improvement, and empowering patients to help manage, their disease or their chronic illness. The good news is, over the 20 years, I've witnessed the power and value of person and family engagement that has resulted in better and safer care. So hearing what Jean Moody Williams said about the beneficiary being at the center of the QIO and CMS initiatives, and hearing Dr. McGann sharing that person and family engagement is going to cut across, all QIO and CMS initiatives. And I love that Janine encouraged you all and did a shout out to, go big. I like the go big message. I'm not only delighted and joyful to be working with CMS, but, as a patient advocate, I see all the opportunities at our fingertips to improve care. And I also am delighted and joyful at the level of commitment that CMS has made to person and family engagement in the QIO program and across CMS that's really tapping into the wisdom and the passion and what we call lived experience of the patient or the person and family communities to really, in the end, to ensure optimal patient experience and health and well-being outcomes that matter most to the beneficiaries. And I think this is just a really strong statement that CMS is putting out there. And in my role, having lived in the patient advocacy world for 20 years, being connected with caregivers and patients and caregiver-patient organizations and clinicians and researchers, I feel the momentum is going to be a big, wonderful asset of ours. And as I get more and more involved at CMS and create the community of patient and person, family, consumer community along with clinicians, and really engage them in all the work that we do at CMS across all the program areas and across all the components. I truly believe we're going to see, including the QIO work, I truly believe that we're going to see improved outcomes in the beneficiary world. And I have to share that as I was watching the chat box, I was delighted, including the polling, that there is enthusiasm around outcomes. And I was watching in the chat box, patient-reported outcomes, and that outcomes, how patients end up really is one of the most patient-centered areas that we could focus on. So I also want to highlight, Paul, our person and family engagement strategy that was just launched in December. For those of you unfamiliar with it, it's on our website. And I must give a shout out to Qualis, because you are my QIO in Idaho, and I just must share that I've engaged with Qualis and the local QIO in Boise, Idaho several times. So I am really looking forward to how the QIOs in the 12th scope of work can really tap into the passion and the energy and the knowledge of their patient and family caregiver community. So with that, I will end, and another big thank you for including me. It was a privilege to be included in this webinar.
Thanks so much, Sue, and as always, your comments are really, really appreciated. At the risk of alienating a few people, we'll get you out earlier. We think we're going to erase the break. Is that right, Bernie?
That's fine.
Is there a tremendous negative reaction to that announcement? Yeah. Oh, good. So I think we'll hand it over to you for a couple questions, and just a warning for the slide takers, I hate to be so demanding, but I am actually going to reverse the order of the 3 questions I'm going to do. So just be thinking about that while Bernie's.
We will. Okay, let's go on to, I think, slide 34, which is question 3. Okay, so now we're asking the question, how can the CIOs better help you accomplish your organization's and your constituents' quality goals? So let's go ahead and think about that and submit your thoughts.
So, Bernie, I just have a comment. I know that we have questions coming in over the chat, and they're furiously coming through. So I did catch 1 or 2 questions about patient and family advisory councils and whether or not the QIOs have them. We do, and so if you go to QIOprogram.org, you can find out which QIO is operating in your state or area and contact them to get connected with the Beneficiary and Family Advisory Council. So we do have that, and we seriously use those advisory councils for all different aspects of our work. We'd like to have a continuous feedback loop with beneficiaries and patients. So if you're interested, please reach out and join one of our Beneficiary and Family Advisory Councils. We would love to have your input as a regular part of our work in the current statement of work. Thank you.
Okay. We have a comment, sir.
Yes, my name is Bill Murray. Patient, first off. I represent the NKF, also the Kidney Active Advisory Council. I'm a member of the End-Stage Renal Disease Network 4 and the End-Stage Renal Disease National Clearinghouse. The CKD prevention and early detection, as you mentioned, can slow ESRD. I was diagnosed in '97, and I was given 5 years until I'd be on dialysis. Changed eating habits, lifestyle, and a few other things. I got 17 years before I had to go on dialysis. So it is doable. I'm a testament to that fact. ESRD options for home-based is probably not part of the QIR here.
That's right. That's correct.
Also, chronic disease management should include CKD, along with diabetes and heart health. And that's because 67% of people that are diagnosed with CKD are led there by diabetes or heart disease. And if you include them in the education and dietary changes, it would go a long way.
Thank you so much, and thanks for taking the trouble to come here tonight.
A couple of things that are showing up online: cancer prevention, detection, improving access to current data, transparency, communicating the total cost of care to patients and providers. And another trend is dealing with palliative care education, advanced care planning. Okay. Well, thank you very much. Anybody in the queue, Patricia?
And there are no participants in the queue at this time.
Okay, so what we want to do is let's go on to the next question, if we could go ahead and to the next slide. what else should CMS know as they start to move in this direction of the new QIO program? What else needs, for example, what else needs to be intricately involved? Who else needs to be intricately involved in doing this work?
So this kind of gets into Kara's concept of collaboration and partnerships, right, Bernie?
Yes,
and I just want to echo what Kara said. You know, the results that came out of the Partnership for Patients, in my opinion, we're still doing the evaluation of that big project, but my opinion is that it was the collaboration that did it. I think if the Partnership for Patients had been designed in a siloed fashion of quality improvement without the extensive collaborations that we had both within the federal government and outside the federal government, I don't think the results would have been generated. So this concept of collaboration is absolutely key. It's difficult to execute in a limited government environment, but I think it's key. So any suggestions you have now in the chat box about additional collaborations we could look for or foster would be really, really appreciative.
Well, and it's happening too. Right before you said that, there was a comment in the chat box about you need to continue to integrate area agencies on aging into the work. They were a key partner in a lot of the work to reduce readmissions and continue to be. And then I saw some others also add area agencies on aging again, pharmacists, EMR vendors. So people are being very responsive to the additional questions that you're putting out, Dr. McGann.
Excellent.
Great. And we have a couple of people who would like to make comments. Please.
Thank you. Adrienne Mims from Alliant Quality, the QIO for North Carolina and Georgia. When we are working with the clinicians, they are looking at the patient in front of them and trying to meet their needs, not what insurance they're on. So it would be more helpful for the frontline people if there could be more collaboration, at least at the level of Medicare and Medicaid for those who are most in need. But then across all other insurers, this disjointed messages that comes across is really challenging for them. Thank you.
Thank you. Okay. One more comment, please, then we need to move on. Thank you.
Great. Good afternoon. I'm Jean Drummond with Healthcare Dynamics International. I love this area of collaboration and really thinking about those non-traditional community partners that can really support the strategies that we're trying to, whether it's around readmissions, just a host of things that we're talking about in terms of just even back to the EDC project of looking at the Mississippi Riverboat or just non-traditional community partners. And it's hard. It really is hard, but it really does cut across the health equity piece, supports the social determinants piece, because there are assets in these communities where we're seeing many of these, the readmissions rates and just, the issues that we're having around population health. So that's what I would really like to see. How can we dig down another level, even below the AAAs, of looking at those communities that are typically seen as vulnerable communities, but there are assets there that know that community, that are trusted sources, that understand how they can bring those resources that they have to support our healthcare systems locally.
Thank you. Thank you very much. Okay, again, we're going to, we have one more comment. One more comment, and then we'll move on to the final three questions, and Dr. McGann will be moderating that particular section. Yes, sir.
My name is Ray Harris. I'm a kidney patient. I started dialysis August 22nd, 1999, 1 month before I turned 25. And just a reminder, just a thought, I'm not a healthcare professional. I'm a healthcare patient. And when I go home at night, dialysis, death, and dying is on my mind. No furlough days for me. All these decisions that are being made, there's people behind it. Not only me, people like Bill. People signed up for it, there's a million others. And until it affects you, it doesn't become important. But there's people behind it, and we have families, we have children in all communities, all people, all races, men, women, and children, especially the black community. We need to be reminded of this and think about it. It's a team effort, and there's no I in team. Team. Together, everyone accomplishes more, and think about that.
Thank you, sir. Thank you.
Thank you very much.
Thank you. Okay, I'd like to turn over the remainder of the three remaining questions. They deal with provider engagement. I'm turning it over to Paul
And I think we're going to build on this gentleman's comment. Thank you very much. And we're going to actually start thinking together and getting your suggestions on how to make this team and connect it to the QIO program of work. And that's really the reason I wanted to do these in reverse order. So slide 38, question 7, please. There we go. That's the last question in the deck. But in many ways, I think it's the most important question of all, which is why I wanted it to go first. So we're focusing now for the last few minutes on patients and the patient's relationship with providers and quality and safety. And I think it builds very nicely on what we just heard. So the question for you is, how can QIOs help integrate patients into quality improvement? We're trying to do that more and more here at CMS. That's why you have some patients in the room. That's why we hired Sue Sheridan. We've got a long way to go. We're very, very far from an ideal state. But because of the comments you're hearing, we're opening the door and we're starting to do that. We'd like you to think for a few minutes, type in the chat and line up at the mics. Do you have ideas for us about how we can do this better? How do we engage patients? How do we get them more involved in design? And how do we get them involved through the entire 5-year QIO statement of work contract? Any ideas you have or suggestions or places to point us as we develop this program of work would be appreciated. And Dennis, you've got really good eyes. I can't read the chat, but if you or Janine, maybe we can rely on Janine. If anything's coming in you want to share, please don't hold back.
Well, I think some of the shortest statements are among the most profound. You know, one is invite them in, and I think that's a big part of it, right? Like we have to include, I think, as a key first step. But lots of recommendations. I see technology is consistently coming up, and I think in some ways this event, this chat, the way all of this is going on, shows the power and the ability to be more responsive to much larger numbers of people in, I think, a very real and authentic way. And I think that's part of the key to unlocking the engagement of patients more fully in design and implementation. I know from our experience with the Partnership for Patients in Hospitals to improve patient safety that one of the things that patients, I think, can do in just really an exceptional way is help these often large and sometimes bureaucratic healthcare institutions to sort of bust through change. There's a lot of inertia, and I think the patient voice really brings an authenticity and a need and a demand for the changes that are necessary to improve the system. And I think that is a very special asset that patients bring. But
Great.
Lots of comments coming in.
We'll keep reading them. I also have other people helping us out here just before we get your comment in the room. These are some of the short points that are coming through in the chat now. Promote the answers to this question. Promote shared decision-making with patients. Make the patient a partner in his or her care. Tell patient stories. We heard some of Sue's stories today. We heard the patient gentleman in the front row tell their stories, and it is powerful, and it does make a difference. I think that is a very, very powerful suggestion. And then the last one, they didn't explain what about it. Dennis referred to it a little, but I think it is true that technology helps. You know, one of our longstanding QIO employees in the regions this week had a retirement party. And Janine, Dennis, and I couldn't be there, but one of our fellow employees here in central office just came in with an iPhone at the end of the day and said, would you like to say hello to this person and wish them a happy retirement? I don't know how to do this, but push the button, recorded a 3-minute video, and sent it across the country, and that appeared at the retirement party. Those types of things seem simple, especially to our children, but I think they can help patients get involved in their care. Yes, ma'am.
And that's a perfect segue. My name is Andrea Goldstein. I'm with Provider Resources. And I think that, you know, when you reach out to the children, you have Stop Smoking campaigns. They'll look at their parents. They'll say, Mommy, Daddy, you can't smoke. Nobody really cares about being a patient until you're placed into that environment. Mm-hmm. I think just like there are campaigns to stop smoking, to wear seatbelts, you've got a campaign to make people aware that it's okay to speak out, that it's okay to ask questions, and that practitioners, clinicians need to also, and there's all this talk now that the millennials are becoming clinicians, that things may change, but I think we've got to look to the youth and raise them to know that it's okay. And that's one place where QIOs might want to think about working, is going out to the high schools, going out to the elementary schools, engage those children so they can be part of the change. They're our future.
Thank you.
Thank you for that comment, Andrea. I saw in the chat a comment about creating courageous patients, and that's exactly what you're talking about. Sue Sheridan is one of those that we have on our staff here at CMS. I also saw another question saying that having a patient as part of the QIO composition should be a requirement. It is, and we do have patients who are participating in each and every QIO organization. And we also, like I said earlier, have those beneficiary and family advisory committees to couple on top of the patients that are already a part of the organization to make sure that we're getting up-to-date feedback about patients that are in the community receiving care day to day. So thank you for that comment, Andrea.
So a couple of minutes ago, I was looking in the back of the room and I saw like 5 people heading to the microphone, and then I looked away for a minute and it was just Andrea. So if there are 4 of you there that are having second thoughts, feel free to get up. We have a few more minutes. From the chat box, we're having people harvest punchy little phrases here, so I'll give you more on question 7. Improve health literacy was one. Create smart consumers of healthcare. I think we heard a discussion of that just now. Start patient engagement earlier in life. A funny idea in Medicare, right? Because we're accustomed to thinking that we start at age 65. And then patient-to-patient communication, which is another very good idea. Yes, sir.
Jerry Rogan, third time. Another story, doctors call me from time to time because they're concerned about poor quality in their institutions. And I got a call a couple weeks ago of echocardiograms not being read for a year. And the doctors who call me are concerned about being retaliated against for having educated senior leadership in the hospital about poor quality. One doctor is being threatened with perverse peer review to kick him off the medical staff because he dropped a dime on these echocardiograms sitting in a drawer for a year. It's the 3rd call I've received from doctors who call me because I'm known in California. If somebody doesn't want to talk to the government, then call me and I'll call the government for them. So my suggestion is that QIO reach out to doctors who work in hospitals and invite them to report quality concerns confidentially so that they can't be kicked off the medical staff for dropping the dime on poor quality that's hurting patients. So if the QIO reach out to doctors to report quality concerns so that they know who to call and what to say without a fear of being disenfranchised from the practice of medicine.
Thank you very much. So I am watching the clock. We have 2 more questions to go to, Bernie, so if it's okay with you, we'll go backwards to slide 37, question number 6. And this now is, again, trying to turn the telescope back to the providers. We have a lot of representation from the QIO community here, but we'd like to hear from providers and patients to imagine in your mind receiving the technical assistance during the 12 statement of work on any of the topics or cross-cutting areas we've talked about. What can the QIOs do best to help you with your quality goals as a provider, as a patient? How do you envision the QIOs working best? We actually heard an example of that with the last comment, but any other ideas about how QIOs can best assist you with your quality goals, providers and patients? Anything coming in on the chat, Dennis?
Haven't seen. Oh, I see people are typing now. That's a good sign. Yeah. Providers need education on how to communicate with patients. That's the first one.
Providers
right?
need.
Oh, Denise has some.
Okay. Oh, great. Oh, let's go to the phone. I haven't heard a phone comment.
This sounds like maybe a response to question number 7. Yeah. Okay. Great. So on the phone.
Who controls the phone?
One moment. And participant, if you don't mind stating your name and affiliation, followed by your question response.
Yes, go ahead. We can hear you.
Okay, this is Lenore Koss. I'm a patient, and I'm associated with Renal Network number 17. I'm a kidney patient, and I'm also a retired nurse of 40 years. And so I tend to look at things from both points of view at this point in time. And my comment was for the previous question. I think it has to do with educating patients that when they want to communicate something that they don't feel is right, that there won't be any retaliation. A lot of the patients that I talk to now are afraid to say what they are thinking or what's going on with them because they're afraid that their caregivers will retaliate. And we need to educate patients, and we need to provide a safe environment for them to be able to talk about their care, what they find good and what they find doesn't meet their needs. And I think this is really, really important.
Thank you so much. It was a very valuable comment, and the two patients that have spoken in the front row here were vigorously agreeing with your observations, so thank you for that.
You're welcome.
And feel free, anyone on the phone or anyone in the room, and especially in the chat box, we don't necessarily have to take the questions in order. So that was what I would call a question 7 answer. So if you're in the chat, you want to answer a different question, just type Q7 so we can sort them out. And same thing in the room. If you don't want to focus on question 6, which is on the board, just tell us what you want to focus on. Go ahead.
Hi, Adrienne Mims, Alliant Quality, QIO, North Carolina and Georgia. We recently held a focus group with some of the physicians asking them if there was information that you wanted to receive and it was through a webinar with CME, what time of day would you want to have it? We started from the morning, went into the afternoon, and the hands raised up 7 to 8.
7 to 8 p.m.
7 to 8 p.m. They're off work, they're back at home, they're able to receive the information. And although we are doing a lot of taping and making it on demand, that doesn't allow for interaction. So I think we need to consider the customer. Thank you.
Great. Thank you very much. So I'm watching the clock, and I want to check the phone again because I thought someone said there are patients on the phone. Are there patients or anybody else on the phone lines? I guess I talked to the operator, do I?
Denise says no.
Nobody's on the phone? No. Okay, good.
Okay.
So I think what I'm going to do then is move to the last question. And then, Bernie, can you remind me, are there things to be done after the last question? Where'd Bernie go?
I'm here. So after the last question, we'll pivot to you and Dennis and Janine providing thank you and next steps.
A wrap up. Okay,
yep,
good.
Wrap up.
So let's focus now on question number 5, which, because we went backwards, is the last question. And this one, I saved it to last because it's a typical QIO question. It's technical. It's important to ask it. Not everybody in the audience is going to want to weigh in on this or would have a desire to. It's less about leadership and culture than it is about the technical craft of our trade. So the question is, question number 5, what quality improvement tools and resources are most valuable to you? Again, it's directed at providers and patients. And I'll just give you an example of the types of things the QIO program traditionally has created. And I'm hoping this creative audience is going to come up with other things that we haven't thought of. But traditionally, we would put together things for collaborative improvement called change packages, which are based on a review of the literature, the quality data that we have, and then an approach, for example, to helping patients in a practice improve their diabetes control and reduce their hemoglobin A1C level. So we would have all the things that are necessary for a provider in that change package. We've also in the past created videos that would sometimes have patient stories in them. We run a lot of webinars in collaborative quality improvement, even at national scale. And then when I first joined CMS 15 years ago, we were really, really big into one-on-one technical assistance, where people that are experts in healthcare quality would actually go out to a hospital or a physician practice or a nursing home and provide one-on-one technical assistance with customized assistance with data interpretation and quality improvement actually on site. That, of course, is incredibly expensive, and it's very hard. At the time, there were 16,000 nursing homes. It's very hard to reach 16,000 nursing homes using that form of assistance. But whatever it is, those are something else you're thinking of. The question is, which tools and resources are most valuable to you? So anything you have to answer question 5, please put it in the chat, and anybody in the room, please feel free to comment.
Hi, Natalie Grace again from the HRAT HIN. One of the things we've seen that has been really successful in the HIN and HEN projects is the peer-to-peer sharing. So any tools that come when a provider asks for something on our listserv platform in particular. The listservs are spaces over email where anyone can ask a question, and we have about 2,000 subscribers. So people ask a question about what they need, and they get lots of responses in real time. So peer-to-peer shared tools and resources seem to be very valuable.
Great. Thank you very much. Anybody else in the room have you been exposed to something that changed your life and helped you improve quality immediately? We're very into here at CMS the lean methodology, so we're using A3s and scorecards. Most of the senior executives at CMS have flown out to ThedaCare in Wisconsin with John Toussaint's organization, and we're learning to use different streamlined tools to continuously improve quality of the processes we have here in the agency. So that's another thing that we've been exploring. Yes, sir.
Yeah, Alex Bardock, Society for Post-Acute and Long-Term Care Medicine. The first I want to echo what Adrian just said. She's done a webinar for us actually about how QIOs can help our physicians to participate in MACRA, and it was, I believe, at 7 o'clock, was it not? Yeah, and we record them. So I would agree that a lot of the MLN Connects webinars and things that do occur, the staff of these organizations listen, but very few physicians are able to participate. So certainly something to think about. The other thing is provide, and we've made these comments to your folks who are responsible for QPP, is algorithms on how to participate. Some of them physicians don't know what MACRA or QPP even is. We do this, I present to our folks and they raise their hands, as you know, as you've done many of these. And so I think a lot of algorithms and simplified approaches on what quality measures are appropriate to you and so on and so forth. So simplifying a lot of this, I think, would be helpful, and demonstrating what's the ROI, what's the value to their patient, because ultimately that's what they ask, and a lot of what they hear is report this and report that, and what they don't hear is what's the value out of it. So maybe focusing on that a little bit.
Great, thank you very much. I've got the latest report from the chat site. Here's 4 more bullets that came in on this question, question 5. Number 1, physician-to-physician engagement. Very interesting idea. For many years, I ran a geriatric medicine fellowship training program, and I know the power of physician-to-physician engagement. So thank you for that suggestion. Number 2, pediatric-related tools. A very interesting question we can't get into today, but I do want the audience to understand that we are authorized by a law, a statute, and the statute tells us, and this kind of overlaps with some previous comments about the Medicaid program, that in the law, which we can't change, we must address the needs of the Medicare population. And that law, which was written in the 1980s, did not include Medicaid at the time. So there are certain things that we are restricted for statutory reasons. Now, it is possible to change laws, but it's important when you're thinking about really transformational change to ask about your statutory authority. And this pediatric question hits that square on the head. Third is video learning tools. And fourth on this list is funding of subject matter experts for regional networks of quality improvement. So those are all very good. Last chance really for anybody in the room. If you have a comment, are there any callers on the line? No callers? And somebody's at the microphone. Yeah. Thank you.
Hi, I'm Dawn Fitzgerald with Adam Alliance, one of the current QIO and QIO contractors, and I know this question was actually targeted to providers, but I'm from the perspective of working with the providers who have talked with us. I think our experience with tools and resources is to the extent that they can be personalized to that care. It doesn't necessarily mean delivered at the elbow of the physician, but when you're talking to the physician, having enough awareness of that physician's what are their priorities within that practice, what are the quality measures they're most concerned about, and so access to data and delivering tools and resources that are very specific, personalized data elements where you can actually drill down and tell them this is your screening rate or this is your data. I think that's very important as a resource. to help them understand, what generates their angst and not necessarily ours.
Great. Thank you, Don.
All right. John Young, George Washington University School of Medicine. So we have a cadre of students coming up. We don't talk about this enough, I don't think, but students are becoming much more aware of quality improvement, quality measurement, the full life cycle of clinical quality, implementation science, team science, and so forth. So I would like to see QIOs more involved in this type of an activity because the academics of quality measurement is really important. Who's the next generation of clinical quality specialists that we're training? So I'm not quite sure exactly where that lies, but I'd love to continue to have that conversation, potentially with QIOs and others.
Thank you so much, John. So we're going to check in with the operator. Operator, I don't know if you can hear me, but we're coming to the end of our time together, and I want to check one more time with the operator if there's anybody on the phone lines that would like to make a comment.
And there are no participants on the phone line. As a reminder, if you'd like to ask a question or make a comment, please press *#.
Okay, thank you for that reminder, operator, and we do have one more commenter here in the room, and I'm going to come back to you in case your reminder stimulated some last thoughts. And then Dennis and Janine, I'm about talked out, so I'm going to be handing it over to you for the closing. Yes, ma'am.
You're never talked out, Dr. Yet.
Andrea Goldstein from Provider Resources. So this goes back to one of the earlier questions, and it has to do with opportunities for collaboration. And somebody who was sitting back here mentioned before about the state focus. Well, the 21st Century Cures Act, there's just an awful lot of money that has now been awarded to the individual states to deal with the opioid epidemic, mental health problems. And perhaps that's an area where right now the monies will be allocated, but for the next go-round, it's pretty much stated. I think Dr. Price said that I'm going to make the states work for it. They're going to have policies and things like that. So it just seems to me that taking the expertise of the QIOs, working within their own states, they could really, really, really push that so that there is evidence-based methodologies going on so that people do have access to care. So that was just my last suggestion. Now I'm quiet.
Okay, thank you. So, operator, did anybody respond to your reminder?
And there are still no participants in the queue.
Great. Well, we want to thank you for your participation. I think we're going to be heading into the closing of this, and Janine and Dennis are going to give you some instructions about what next steps are. This isn't your last chance to comment, and I think we have slides that outline that have already appeared on the board. But I just want to add a personal note of mine. I dedicated myself after I got into medical school to the care of the frail elderly. The average age of my patients was 85. They were all on Medicare and Medicaid, and I specialized in people over the age of 100. And ultimately, I came to Medicare because I thought the system could be improved. What I saw on the front lines just wasn't doing the trick for my patient population. I made that difficult decision 15 years ago, and I have to say it's been the best chapter of my life working for this agency. We still aren't where we need to be, but we've made so much progress forward, and I think the agency is becoming more and more open and interactive, not only with providers, but with patients as well. And I just want to reiterate that our ability to convince Sue Sheridan to come and be a CMS employee will always be one of the highlights of my career at CMS. I want to thank you all for turning out and going through this marathon session. Thank you for your wise opinions and input, and thank you out there on virtual land for the chat box, which is absolutely wonderful. We save it all. And I'll turn it over to my colleagues to close us out.
Thanks, Paul. So I'll let Dennis have the last comment, but I will share that I also joined the federal government 15 years ago at the very start of my career. And also, like Paul, I think this was the best decision that I've ever made in terms of a future progression. We really are here to change the nation. We need your input, critical input, smart input, and wise input about what we should be doing going forward. We cannot put this massive amount of work together without your input. And when I say that, I mean patients, current QIOs, and future QIOs. So we implore you to use the resources that we've shared on these slides to communicate with us. We will take all of your input into consideration and plan to use it as we go into this development phase of the cross-scope of work. So I just want to thank you all for being here, and just know that we really appreciate you sharing the time with us today. Dennis?
Great. Yeah, thank you, Janine and Dr. McGann. And I kind of want to double down on what you said just a few moments ago. It is our intention to take your input and to use it. We want to use as much as we possibly can. And at some level, I look at the chat, and there's lots of input coming in on the chat. This isn't the first listening session we've had. We've had others. So we're getting a lot of feedback, and we're getting a lot of input. It's a lot to get around, but our intention is to do so. We want to put this input to work. Now, I also want to just note that we've got 2.5 years of work in front of us with the 11th scope of work. We have a robust resource program of work to do technical assistance and quality improvement at a national level. And many of the ideas that are coming to us here aren't things that we're going to wait to act on until August 1st of 2019 with the 12th scope. We get a lot out of these sessions that we know that we can put to work right away. So that's also our commitment is as we see good ideas or as we see offers or suggestions for things that we should be doing, we want to put them to work just as quick as we possibly can. So we're eager to have your input. I would say that we also know from experience, it's not just what you say to us about what we should do, it's about what you do with us, right? The systematic engagement and involvement of patients in our work has made a tremendous impact. It's helped to generate the kinds of results that we've been talking about here, that you heard Kara James talk about. And I love the comment that was made by one of our patient representatives earlier. Together, everyone achieves more, is what I wrote down, TEAM. And I think that's just the God's honest truth. It's when we work together that we surface the joy, that we surface the energy, that we surface the ideas and the possibilities, and ultimately the actions that make things better. And that's our plan. That's what we try to do every single day in our work. It's what we want to do more of, and we need to be in partnership with you to do it. But I'm just going to add my voice to Janine and Paul's. I love this work. I think this is a blessing to be able to do this kind of work and to be able to do it together with people like those in the room and those that have joined us here today on the chat. So thank you for being here. Thank you for your ideas. And thank you for the work you've already done and that you will continue to do with each other and with us.
And just before we close, because I'm a good government bureaucrat, we have communication strategies and channels open to you. On this slide, which is slide 39, because this is a very large federal procurement, it abides by all federal procurement laws, and those laws require open and public information sharing, and it requires free and open competition without any favoritism or directing specific information anywhere. So if you want to keep track of this procurement, it's still 2.5 years away, but it takes this long to get it out. Follow us in the Federal Register. All of the official notices are required by law to be posted in the Federal Register. The Federal Register's URL is up there, www.fbo.gov for Fed Biz Ops. That's where all the procurements are posted. And if you can go to the last slide, for those of you whose computer broke or you're on a plane or you couldn't make it work here, if you want to send additional comments, we have set up a special QIO program email box at CMS, and that's on the screen here. QIO program, all one word, at cms.hhs.gov. And unless I get signals, am I supposed to do anything else? We'll close it down, and thank you for your participation. I hope you have a wonderful evening.